Alright, here we have the picture representation of nephritic syndrome. And nephritic syndrome, the presentations are on the right hand side here. You get a glomerular hypercellularity. So you've got all these glowing rulers, that are lots of them, so they're hyper. You get a lot of glomerular hypercellularity. And that leads to a decrease in GFR, decrease in sodium excretion, and decrease in the renin-angiotensin system, or RAS. So you've got this decrease because what's happening is this big dam over here is stopping the sodium in the water from being released. So you got the sodium and water retention that leads to hypertension. So you've got the blood pressure cuff there, hypertension, edema of the face, hands, and eyelids. So that's what that leads to. Now you're going to see a presentation of red blood cell casts in the urine, hematuria, and those are kind of what's classic for nephritic syndrome, is you're going to see the blood. And over here you've got Alport syndrome. Alport syndrome is a genetic disorder, and that's why he's got an X on his shirt here. He's got an X. It's a genetic disorder that is it results in a mutation. It's usually dominant, but it results in a mutation of the alpha 5 chain. So there's this break in this alpha 5 chain over here that has to do with type 4. See type 4 right here, collagen. So the defect in the alpha 5 chain, type 4 collagen, that causes a lot of problems. Which one is nephritic syndrome, but there's also a triad of nerve deafness, so he's deaf, cataracts or lens dislocation or corneal dystrophy, plus the nephritic syndrome. It often presents with the hematuria or erythrocyte casts, but if you find somebody that might have had nerve deafness or cataracts also with that, you can wonder if it has to be related to this genetic disease. So 10-year-old boy presents to the clinic complaining of blood in the urine. You find out that he's got mild nerve deafness and also posterior cataracts. So those are all part of Alport syndrome. Membranoproliferative glomerulonephritis type 2. And the reason it's type 2 is type 1 is more of a nephrotic syndrome, and type 1 is nephritic. And what you're going to see is a lifting of the endothelium to make humps, and what might be described as a tram track appearance on light. See the light? Microscopy. Now this happens, the tram track appearance happens because there's a splitting and expansion of this mesangial matrix into the capillary loops. So that's kind of the definition of a tram track. They might not say tram track, they might say splitting and expansion of mesangial matrix into capillary loops, and that's the tram track appearance. Under electron microscopy, you're going to see dense deposits of homogeneous material within the glomerular basement membrane. So you're going to see just deposits. It's called double contours. Treatments, corticosteroids and antiplatelet drugs. So that is the membranoproliferative glomerulonephritis type 2. Over here is post-streptococcal glomerulonephritis. Now you've got this glowing ruler, so glowing glomerular nephritis. It's most frequently seen in children following an infection, and usually of group A. So there's the A, beta hemolytic. So the beta is hugging the blood cells. So beta hemolytic group A, and streptococcus also can present with periorbital edema. So that's why there's a red around this little acute strep. And you got a lumpy, bumpy appearance on the immunofluorescence. So it has to do with coarse granular, immunofluorescence for IgG or C3. So it gives that lumpy, bumpy appearance. For instance, maybe a 10-year-old girl presents to the clinic complaining of eye swelling. There's the periorbital edema. You remember the child from 3 weeks ago when she was there for pharyngitis. Upon taking history performed, you find that the patient has pronounced periorbital edema, been urinating very little despite adequate fluid intake. The blood pressure that's high. Lab findings include azotemia, hematuria, red blood cell class in the urine, and increased ASO antibody titer, which shows that they had strep. And it usually resolves spontaneously, but it's an immune complex disease. See that the antigen antibody type 3 in origin, and you'll see decreased C3 on the labs. Goodpasture syndrome up here. You've got the pastor up there with his good book, and there's lung manifestations with this also. But for the kidney, it often progresses over here to rapid progressive glomerulonephritis. But what you've got here is a linear pattern of immunoglobulins. You've got anemia, the red blood cells. You've got often hemorrhaging of the intraalveolar hemorrhages. We talked about linear. You've also got anti-good book or anti-GBM, or glomerular basement membrane antibodies, which is a type 2 hypersensitivity, and it progresses to the rapidly progressive glomerulonephritis. That's the type it is. Now, this is also post-streptococcal in about 50% of the cases. Other causes are immune types like lupus, IgA, Schoen purpura, Wegener's, and Goodpasture's, which we just talked about. You're going to have a formation of a crescent moon shape between Bowman's capsule and glomerular tuft. It can progress to rapidly to renal failure within weeks or months, and you've got to treat with dialysis or transplantation. For instance, you might have a 40-year-old white man is admitted to the hospital with complaints of blood in his sputum, a history of fever, malaise, 10-pound weight loss in the past month. Physical exam, you find his blood pressure is high, and several abnormal lung sounds. Urine dipstick is hematuria. Chest X-ray reveals nodular lesions. Presence of Cianca, which would have to do with Wegener's. Elevated ESR. You start the patient on high dose of corticosteroids and do a renal biopsy, and you'll see the Bowman's capsule, and so you get this rapidly progressive glomerulonephritis. Now, IgA nephropathy, also known as Berger's disease, so there's a Berger's disease. It's often seen with Schoen purpura, so there's all these purpura. It's seen in children and young adults, and men are affected more than women. You've got mesangial deposits of IgA, and you've got this widening of the mesangial area, diffuse mesangial widening. In light microscopy and electron, you're going to see the mesangial deposits of IgA. You're going to see hematuria 1 to 2 days after an infection. You're going to see increased serum IgA levels in about half the cases. You treat with prednisone. And Berger's disease is the most common form of acute glomerulonephritis in the United States. It's present in Asia also, and can be cause of recurrent hematuria. For instance, a 15-year-old Asian American boy presents to the emergency room frightened by his red-colored urine. Upon history, you learn he's suffering from strange flu-like symptoms that began 2 days earlier, consisting of vomiting, myalgias or pain in his muscles, arthralgias or joint pain, fever. Serum studies reveal IgA levels and normal serum complement levels, so that's the big difference. You begin with prednisone and suspect he's the most common form of the glomerulonephritis. That is everything.